Well, good afternoon, everyone, and thank you for joining us today for this virtual town hall for DGSOM faculty. I'm Jonathan Hyatt, Vice Dean for Faculty, and before we get started, I'd like to just go over a few housekeeping items. You can submit your questions during the presentation using the Q&A feature in Zoom, and we'll answer them either in writing or verbally by the panel to the best of our ability. We have received some questions in advance of the meeting that were submitted online, and we've tried to answer almost all of those. There's one that we'll do our best to answer during the session. We are recording the meeting, and we'll be making the recording available for playback after the meeting concludes. Next, I'll welcome Dr. Kelsey Martin, Dean of our school, for her opening remarks.
Well, thank you, Dr. Hyatt, for organizing this town hall. I want to thank the panelists. I want to thank our amazing IT staff, and mostly I want to thank all of our faculty for participating and for all that you're doing as we navigate this, the COVID-19 pandemic. I also want to welcome and recognize all of our affiliates. We are a remarkable public medical school, and we have a mission to serve our city, and we can only do that in partnership with all of our affiliate institutions. This pandemic is really creating an unprecedented, every day, every moment, there's a change in our in every aspect of what we do. It is affecting all of the missions of the School of Medicine, the clinical care mission, the research mission, the education mission, and the community engagement mission. And what I've seen over the last several weeks has really been just as there's an unprecedented change and challenge, there's also been an unprecedented level of collaboration and communication amongst the faculty, the staff, and the trainees in each of those mission areas. Every day, the school working closely with our healthcare system to ensure that we're able to provide the best and the safest care to our patients, that our faculty and our trainees are safe. In the education realm, we've made incredible strides in moving to remote education. In research, we've brought together all the amazing talent and creativity of our research faculty to come together to try to understand how do we actually identify solutions to this pandemic, and how do we think about how as a healthcare system and healthcare systems we're going to be able to address similar pandemics in the future. It's also, and I would say that all of those activities have been incredibly heartening to me. They fill me with hope for our ability to address this challenge. There are also sobering realities to our current state. Because of the losses in clinical revenue, I can tell you that in the school, we are losing about $80 to $100 million a month at the moment. And what that means is that going forward, we're going to have to be work very closely in partnership with all of you to be able to accomplish our mission areas, and to do that in a way that allows us to be impactful given all of those constraints. So over the last weeks and also coming into the future, I am working very closely with the chairs. We'll be working closely with all of you as faculty to do all we can to ensure that we continue to really reach that promise that academic medicine has in addressing these unbelievable global challenges like the COVID-19 pandemic, and that we do it in a manner that really embodies the tenets of the cultural North Star, in which we do what's right and we make things better and we be kind, and we do that in a way that also reflects all of the important attributes that we embrace at the David Geffen School of Medicine of being an inclusive and diverse environment. So with that, I'm going to turn it back to you, Dr. Hyatt, and again, thank you.
Thank you, Dr. Martin. I'm going to make a few brief remarks because despite serving as Vice Dean for faculty in the School of Medicine for the past nearly 8.5 years, I've never had an opportunity to address, at least in theory, the entire faculty. And if a crisis of this sort is the reason to do so, I frankly hope it won't become a common occurrence. I've been a member of this faculty for 38 years and always intensely proud of it. Over the years, I have worked most everywhere that UCLA has faculty, at Olive, Harbor, the VA, Cedars-Sinai, and on campus. My colleagues have invariably been the best physicians, the best teachers, the best scientists, and the best people. My clinical work was as a trauma surgeon in the discipline now known as acute care surgery. And in that role over the years, working together, we've been through a lot. I've worked alongside UCLA faculty in the responses to calamitous events made by nature and made by humankind. We were tested in those events and we responded well, but they pale in comparison to the worldwide crisis we face at present. This crisis is testing us in ways that I have barely imagined. We are tested in the care of our patients, the education of our students, the pursuit of our science, the service to our communities, and the management of the resources needed to do all of those things, in particular when the crisis has passed. Our goal today is to provide an update about where things stand in relation to topics we hope would be of direct interest to faculty, to answer your questions for which we have answers, and to pledge to find the answers to the ones for which we don't. I'll conclude my remarks by saying, fellow faculty members, today more than ever, I am privileged to be counted among your ranks. I'm also privileged to introduce our next speaker. He is Dr. Michael Levine, UCLA's Vice Chancellor for Academic Personnel, and as a faculty member, a research scientist in the Department of Psychiatry and Biobehavioral Sciences. Dr. Levine will make a few remarks about academic personnel processes and related matters. Dr.
Levine. Thank you, Dr. Hyatt. As Dr. Hyatt said, I am faculty in the School of Medicine, like all of you. And the last 3 years, I've been the Vice Chancellor for Academic Personnel. So I come from the same place as all of you are. And I'm sure I will just keep my remarks very, very brief and just aimed at one area, which is review, academic review for promotions and merit advancements and things like that. Because that's what many of you probably are going to be concerned about as we move forward in this era of COVID-19. First of all, I want to reassure all of you that the review process is going to remain as it is, but it's going to become much more flexible. We are going to take into account all the things that have happened to faculty based upon their experiences with COVID-19 and how they have changed the ability of faculty to continue with their accomplishments or to make additional accomplishments as they move forward. And this will occur all across the different ranks and steps and different series that faculty are associated with. Just to give you some examples, those of you who are assistant professors, if you feel your fourth year review needs to be delayed a bit, we will take that into account and certainly allow that to happen. For others, if you're putting together your files and they need to be delayed because you're involved in more clinical work or you have childcare or other kinds of issues, those will all be taken into account. Without going into details, what I would say is that if you have issues in your reviews that you want to be made known, put them in your self-statements. That's the place where reviewers can best see what you've done and how it's all been affected by COVID-19. So I'm going to stop here. And if you have questions, just submit them and I'll do my best to answer them when the time comes. Thanks, John.
Thank you, Vice Chancellor Levine, and thank you for your tremendous support of our school always over the years. Next is Dr. Lynn Gordon, Senior Associate Dean for Equity and Diversity and Inclusion in our school, for her remarks about this critically important area during these times. Dr. Gordon.
Thank you so much. And I really appreciate the opportunity to speak for just a couple of minutes. At this time, it's really critical that we renew our commitment to our shared values of equity and diversity inclusion. We increasingly hear about prejudicial acts, words, or comments that target vulnerable populations. We know that individuals from particular backgrounds, especially Asians, have reported discrimination and bias in their neighborhoods when they're out getting critical food or medications, and in work environments as well. And we've heard from individuals within our own UCLA DGSOM community about their experiences with these events. As the virus spreads, we still have to protect ourselves and the fabric of our communities. And we accomplish this by both providing excellent medical care, by doing amazing research, but also by condemning xenophobia and racism very strongly. And I just want to highlight two additional areas that I think we haven't spoken enough about. And one is the effect of COVID on individuals with disabilities. We know that we have many in our community, and for those that are patient care facing, that we have many patients that are hearing impaired, and seeing faces is very helpful. Yet when we're in mass, if we're seeing patients face to face, it makes it more difficult for them to recognize what we're saying. And so we really need to think critically about how we're communicating in the patient care arena. And then the other issue that I wanted to highlight is the prevalence of infection and the numbers of individuals that die from the disease, which has been disparate across the country in terms of race and ethnicity. About a week or two ago, many asked the CDC to start publishing these numbers because initially they weren't, but now they are. And in the first month of the pandemic, data from across the country suggests that about 33% of those that were hospitalized in that first month were African American or Black, but the overall US population is 13%, so an area of disparity. Yesterday, the California Department of Public Health posted that type of information for about 54% of cases to date in California. And I'm happy to say that in our state, the differences don't appear to be quite as dramatic as they are in other parts of the country. But we are seeing differences in who's working, who's losing jobs, and food insecurity, all of which are concerned to the fabric of our community and is really sobering as long-term consequences of this pandemic. I know that this is a time of great stress and uncertainty. We're here for each and every one of you if you have EDI concerns. We've also published on our website some suggestions for actions that you can take. But right now, even more than ever, it's important to abide by the cultural North Star and do what's right, make things better, and be kind. Thanks so much.
Thank you, Dr. Gordon. Next is Dr. Clarence Braddock, Vice Dean for Education in the school, with his comments about what faculty members can expect in relation to classroom and clinical teaching over the coming weeks and months. Dr. Braddock.
Thank you, Dr. Hyatt, and I want to thank you for the eloquent remarks earlier, which I think were really spot on. Just a few words about the education program, and as Dean Martin said, I think our challenge is how do we grapple with the unique circumstances that this pandemic has brought, while at the same time trying to continue to advance our mission. In the education space, I call that education continuity, and that's been very much our philosophy. I'll say a few words about the medical student program and classroom teaching, and a little bit about our residency education as well. As many of you know, since early March, we've migrated almost all the classroom education, in fact, virtually all the classroom education for pre-clerkship students and for any other instruction into a remote format. Now, what that might sound like, just videotapes, and that does involve some of it, but we've been very fortunate to benefit from tremendous partnerships with our colleagues in the education technology service within the School of Medicine and across the campus. And there are many, many resources for faculty for classroom teaching, small group instruction, et cetera, to leverage technologies like Zoom to be able to have very interactive, very engaging, and very educationally beneficial activities. On the campus, the Center for Advancement of Teaching is a wonderful resource and has put out a number of teaching tips and things are available for consultation, as are my team and members of our education technology service. Medical students in the clinical environment, on March 16th, we made a decision for third-year students, as you know, to remove them from the clinical environment. Just to say a word about that, largely I would view that as a balance between educational continuity and our obligations to, as individuals, to contribute to controlling the and the decision was made that students should stay at home like folks who aren't in critical roles as frontline healthcare workers. But I'm grateful to our faculty colleagues and all the clerkships who have marshaled some amazingly creative solutions to keep those students engaged in learning in their clerkship specialties, have them be prepared for the next phase of training when in fact we can return them to the clinical environment. Our fourth-year students are in selected clinical environments, contributing both to the workforce of taking care of patients, COVID positive and otherwise, but also importantly preparing for their next phase of training in residency. I'm happy to answer more questions about the particulars with our student programs. Let me just say one word about GME. Our residents and fellows are a remarkable group, outstanding people, outstanding clinicians, and their dedication and commitment to providing care for our patients during this time has been nothing short of inspiring. I'm in internal medicine. I'll give an internal medicine example. I know that when creating the COVID positive service at Ronald Reagan, the program sought first to get volunteers, and dozens of residents volunteered to be on that service. That shows the spirit of our house staff and the recognition that we are, as Dr. Hyatt said, in an extraordinary time, that we're all challenged, and then many are challenging or stepping up to that challenge. My colleague, Dr. Kate Perkins, who's the Associate Dean for GME and our DIO, has been very active and instrumental in assuring that we're paying attention to the needs of house staff with regard to all the things to support them, help them keep safe in that environment. And I'm very grateful for her commitment and amazing work, working both within our campus, but also with our affiliates. So again, I'm happy to answer your questions as we move forward into Q&A about the education program, but I want to thank all of you who are involved in teaching. I'll let you know if you have questions and need help in migrating to the remote teaching format. But again, just a lot of gratitude for all the work it's taken to get to where we are now. Dr. Hyatt.
Thank you, Dr. Braddock. Next is Dr. Stephen Smale, who serves as Vice Dean for Research in the school and will be providing an update on the many areas in which he and others have been working in relation to continuity of research activities. Dr. Smale.
Thank you. So as with all the other areas that you just heard about, that it really is an amazingly unprecedented time for our research enterprise, that at one level, it's been necessary to really ramp down almost all of our research activities, especially within the laboratory setting, where only those experiments that are considered to be essential or very difficult to ramp up again have been permitted to continue. I really wanted to thank all the faculty for handling this so responsibly. It was really gratifying as the person that had to go through all of the requests for essential experiments to see how responsibly everybody handled this. There were almost no requests for frivolous needs. That the requests that came through were really for experiments that legitimately had to continue during the ramp down because of the nature of the experiments and the cost that would be associated with it to really have to terminate things prematurely and then try to ramp up again. And that ramp down really needs to continue. We don't know how long it's going to need to last yet. We have not gotten any recent word from the campus of what they're thinking of a time when we may be able to ramp up experiments. It's something we're really interested to know and eagerly exploring with the campus, but at this point we just don't know. But it's very important to maintain that ramp down, effort, because we don't, if people start creeping back into the labs prematurely, that could just lead to a backlash of having more restrictive policies. So again, I wanted to thank everybody for what they've done, and encourage everyone to continue it until an appropriate time. At the same time that that's had to happen, of course, there's just unprecedented activity on the level of COVID-19 research, both in the clinical and the basic science directions, that there were many faculty who jumped into this right away. But even now, just every day, there's 2 or 3 more faculty, either basic scientists or clinicians or translational researchers, that are contacting me with new ideas about how they can use their expertise to contribute to this problem. And it's really gratifying to see this. And essentially, the campus is allowing all COVID-19 research that's considered to be legitimate to take place at this point. But the volume of research in this area is so high, and so many people are wanting to get into it, that it was really important for us to develop an organizational structure through which the research could be coordinated. And we announced that about a week ago, where this involves an oversight committee that is chaired by Owen Whitty, that will evaluate requests for funding and other resource needs at a very high level. And that committee then will also oversee 5 other task forces, which include a clinical research task force that is chaired by Arash Naeem and Judy Courier, a basic science task force that's chaired by Gay Crooks and Emily Marcus, a high containment facility use task force chaired by Jerry Zach. And this is a task force that was implemented or just announced by the Vice Chancellor for Research, due to the fact that the number of faculty and labs that are interested in using our BSL-3 high containment facility for COVID-19 virus research has exploded. And there's a need to make sure that we can coordinate all of that utilization and make sure the facility can manage the volume of requests. There's also being developed a committee that will be referred to as the COVID-19 Scientific Priority and Feasibility Committee, which is really charged with trying to deal with the fact that we that even on the clinical side, that there's an overwhelming volume of requests for patient samples, for initiating new clinical trials with COVID-19 patients, for getting access to data. And there's a potentially an inability to meet all of those needs. So there's a committee that will evaluate those requests, look for efficiencies, prioritize the requests to make sure that we can be as impactful and responsible as possible in performing this research. And then finally, there's a committee that is chaired by Mike Pfeffer that already exists, a health data oversight committee that will look at requests from third-party requesters for data related to our patients. I especially want to really thank Arash Naeem and Judy Courier and their clinical research task force, which got going very, very quickly and has been just unbelievably effective at getting a number of clinical trials off the ground at record speed. And this involves really unprecedented speed by the IRB, and also by the sponsored research contracting groups that have allowed a number of trials to either be launched at this point or in the process of being launched in the near future. It's really been remarkable to see the activity and the progress on the clinical side that has that has put us in the best position to really help the patients that we can be in. So all of this is still under development. I think the charges of some of these committees are still being refined, but we have an organizational structure, and please pay attention for other communications that hopefully will be coming out in the near future that will refine the methods for requesting biospecimens, for suggesting ideas for clinical trials, for accessing the BSL-3 facility, et cetera. Thank you.
Thank you, Dr. Smale. Next is Dr. Robert Cherry, who is the Chief Medical and Quality Officer for UCLA Health. Dr. Cherry has been one of the central figures in the command center, planning and implementing the health system's response to this crisis. He'll say a few words about UCLA Health surge planning in related areas, including personal protection. And I want to note that Dr. Cherry has to leave at 1 p.m. for another meeting, so please submit questions in his area as soon as you can. Dr. Cherry.
Thank you, Dr. Hyde. I appreciate the invitation and the opportunity to talk to faculty. I will say that the early decisions that the state of California has made and Los Angeles County has made in terms of school closings and stay-at-home orders have been impactful in terms of being able to keep all of us safe and also to protect our health system so that we're not overwhelmed by COVID-19 patients, so that we're able to take care of this incremental surge in a much more thoughtful fashion and be able to care for them really effectively. We are very cognizant of the fact that with those stay-at-home orders comes a great deal of sacrifice by many in our community, because in many cases it's led to loss of income and significant disruption. But I do want everyone to know that those sacrifices are resulting in a curve that does not look as steep, so far. Though we're seeing increases in confirmed cases, increases in hospitalizations, increases in deaths, we're not seeing anywhere near the slope of the curve being as steep as they are in places like New Orleans and Detroit and New York City. So for that, we're certainly grateful for. And what this has allowed for us to do is to allow time for many of us to plan and prepare and respond accordingly. We are seeing COVID-19 patients in our hospitals. We've been averaging over the last several days around 40 of those a day, with about 15 on average in our intensive care units, most of which are on ventilators. We have made some interesting novel strides, though, in terms of dealing with this pandemic. We've seen an increase in telehealth visits. We've been able to ramp up on that considerably. One of our main concerns with people staying at home is deferring their care, and we want to make sure that that's not adversely impacted. One of the things that we're doing to make sure that we can bring people back into the fold in a very thoughtful way is through universal testing of our inpatient population. That will be fully launched on Monday, and that will allow us to make clinical decisions around patient care in terms of preoperative patients, pre-procedure patients, ED admissions, and to be able to care for them and hopefully decrease the number of patients that are being deferred in the coming days and the coming weeks as well. Many hospital and health systems, as you know, have been overwhelmed with supply chain issues. We've had an expert supply chain team that's been really managing this hour by hour in a way that has been very, very helpful to all of our frontline staff. We're finding longer term sustainable solutions in terms of being able to be as self-sufficient as possible. The medical students have been terrific in helping us actually assemble thousands of face shields for our frontline clinical staff, and I just want to thank them for spending hours and hours doing that for us, and it has been a tremendous benefit. The same is true for our campus colleagues, or our engineers in the School of Engineering has been helping us develop longer term face shields using injection molding technologies, and also special devices for respiratory infection, for respiratory protection called PAPRs, and we've been developing prototypes in collaboration with engineers as well. All of this allows us to extend our supply chain and be able to manage the influx of patients. There's certainly a feeling of optimism as we continue to march through the COVID-19 population that we're caring for. But most importantly, I think we're really part of a resilient organization. No matter what the new normal looks like, I think we'll come out of it actually much stronger than what we are.
Dr. Cherry, I'm going to go a little bit off script and ask you if I could, if you wouldn't mind just answering a question that's come in. The question is, why is the hospital not mandating universal masks for anyone entering the hospital if the rest of the city is? Recent email suggests just permissive masking, which seems counterintuitive given the patients and healthcare workers who are at greater risk of getting COVID and at greater risk of severe illness.
Yeah, and it's a really good question. I get asked that, and others get asked that all the time. So I think all of you are familiar with Mayor Garcetti's directive in terms of the public being encouraged to actually wear face coverings. And I should emphasize that face coverings is different than hospital grade face masks. And so it's a different directive, and it's not actually mandated for academic institutions and healthcare settings, and particularly healthcare settings for the reasons that I mentioned, because they're not hospital grade. What we've developed is permissive masking, and that's which does allow for people that are working in the clinical setting to be able to wear a mask that's hospital grade to make them feel more comfortable. We have not done what's called universal masking, which is where for every person that comes in, we're handing them their own mask for the day. One of the things that we do know that when we talk to institutions that have done that is that results in a doubling of the utilization of those particular types of hospital grade masks, especially the N95s that are such a premium right now. So if you look at surgical masks in general and the N95 masks, our current burn rate is roughly around 15,000 of those masks per day. And so if we were to take our existing census, because we've revved that down quite considerably in order to prepare for any type of surge. And if we were to add them back on to our normal capacity with COVID-19 patients, our burn rate for those particular masks would go from 75,000 to 75,000 per day, or about 2.25 million masks per month. And so what we're really trying to do is make sure that there is availability of masks at each of the clinical work areas that people are working in. We're also, in addition to some of those sustainable solutions that I've mentioned with the medical students and the engineers, we've also given guidance on extended use and reuse, and have used innovative technology using ultraviolet light to actually disinfect our N95. So there are 7 units between both campuses, Santa Monica and Ronald Reagan, that we've co-localized COVID-19 patients. 5 of those 7 we've gone live with already on disinfection of N95 masks for reuse. So we're trying to manage the supply chain in a way that allows us to get through the peak of the curve, whatever that might look like, so that we don't run out at any particular point in time.
Thank you, Dr. Cherry.
Sure.
Maybe another 1 or 2 that we'll get to, but we'll keep going for the time being. Really appreciate your being here. Next, in concluding the formal portion of our program, our 2 infectious disease experts, Dr. Risa Hoffman, who is director of the DGSOM Global Health Program, and Dr. Annabelle de St. Maurice, who is co-chief infection prevention officer of UCLA Health. Thank you both for being here.
Hi, thanks. So I'll go ahead and get started. And just wanted to thank you for having me present. I'm really here on behalf of the entire Division of Infectious Diseases. And we have been working very hard to try to provide excellent service to the faculty and trainees and the patients. We've developed dedicated COVID services in both Santa Monica and Ronald Reagan, and are working with the pulmonary critical care, hospitalist palliative care, in a multidisciplinary way to make sure that we have, really integrated treatment guidelines and are thinking really in a cross-disciplinary way about this infectious disease. We have the privilege of having a cross-campus fellowship training program. So the faculty and ID are very connected across Cedars, all of you, and the VA, and we have a weekly conference where we share our experiences, and we have been sharing our treatment guidelines and our challenges and discussing cases in a way to try to help really across the campuses to be a unified group and do, provide the best opportunity for everyone at these different programs to have up-to-date information. From the outpatient standpoint, we've developed increased availability for e-consults, so you can directly have a physician-to-physician encounter, and also for ID telehealth visits for patients that are in the outpatient setting to provide direct clinical care without in-person encounters. In regard to the clinical trials, which Dr. Smale mentioned, it really has been an incredible effort by lots of different divisions and departments. We currently have, I think, at least 4 or 5 open, including the antiviral remdesivir, 2 IL-6 inhibitors. There's a couple opening up novel approaches, including an HIV CCR5 blocker, leronlimab, an oncology drug called selinexor. Those are very on the pipeline to be opening soon. We also are trying to, those trials are for Santa Monica and Reagan patients. We're cognizant of wanting to have opportunities for others outside of the UCLA health system. We have an outpatient study of hydroxychloroquine azithromycin that's going to open soon. That would be available for outpatients across the county if eligible. And we're next week going to open a post-exposure prophylaxis study. So for those who are exposed either in the household or high-risk healthcare worker exposures, and for anyone that has questions about these outpatient studies, I can be a point of contact for you. And then there was a question about screening of healthcare workers. So there's another study that's going to open hopefully next week that's going to be offering to healthcare workers, including you all as faculty, to have mid-nasal swabs every 2 weeks. We'll look at COVID PCR and then monthly antibody testing. So there should be some further information coming about how you can be connected to the study team for that. Moving to the testing and laboratory, our microlab is incredible, as most of you likely know. We're currently able to provide over 1,000 tests a day. I think as of today, very exciting, are no longer sending to Quest and doing all of our tests in-house, which is going to improve our ability to provide much faster results, less than 24 hours to all patients. Additionally, there was a question about antibody testing. Starting next week, our lab will be able to do send out antibody testing for clinical use. So that is going to be available at some point in the next week. And finally, just in terms of the support for healthcare workers, if for faculty, if you all have concern for yourselves or for any of your team members, there's a nurse hotline. It's been heavily advertised, but just in case you don't have it, 310-267-3300. You can call that number if you are symptomatic and think you need testing, if you've had an exposure and want to know what to do. So 24/7 support for you and for any type of healthcare worker for whom you might have concern. So I'm going to stop there, and I'm always available outside of the town hall for questions.
I
Should we
can
go?
go ahead. So thank you all again
Yes.
for your support and all of your questions and interest in COVID-19 during this difficult time. As Dr. Hoffman went over a lot of the inpatient testing, I will just remind you all that we are implementing testing for all admissions to the hospital, and that will allow us to more judiciously use our PPE. And this will be regardless of whether or not a patient has symptoms or not. And hopefully this will help prevent exposures amongst our staff. We're also testing patients preoperatively, and I did respond to one of the questions during the Q&A about our positivity rate. And part of this is likely due to the fact that we are testing a lot of patients who are asymptomatic and unlikely to be infected. As Dr. Hoffman mentioned, we will be soon in the next couple weeks testing via serology, which will help both for healthcare providers who may have been exposed, and then also potentially could be used for patients as well. We're still figuring out how to really use the serology in a way that's meaningful. It would not be recommended for diagnosis of acute infection, but could be used to assess for somebody who may have been exposed in the past. We continue to work on our PPE supply and demand. One of the things that we have been working on is the UV gamma irradiation. One of the questions that came up in the Q&A is regarding the safety of this. So this has been vetted. It's being used at other centers, including the University of Nebraska, which is one of the leaders in emerging infectious disease treatment. Certainly the specific question was regarding the elastic straps, and we do know that these can wear over time, so that's why we are only recommending that we use the N95s 5 times after the masks have been irradiated. We also recommend staff to check the fit of the N95, both the wire and then the straps, prior to entering a patient room in which they would be using that N95, and certainly if they have concerns about the fit, that they would get a new N95. I think this process will really help us expand our PPE. We've had really great success in the areas where we've trialed this, including our 4 ICU and 7 East and Santa Monica. We are continuing to do surge planning, and we really appreciate all of you that have been working on this. And we've been working on developing hot, warm, and cold zones for some of the units that are seeing these patients, so that we can minimize donning and doffing of PPE and take care of these patients safely. Thank you.
Thank you very much. That concludes the formal portions of our presentation, and now we're going to try to work through some of the questions. Dr. Cherry, I think there were a couple that you flagged, and maybe could I just ask you to take those? I think the first is, what are the status of temporary face shields for PAPRs?
Yeah, so PAPRs is a sort of advanced form of respiratory protection against viruses like coronavirus. We actually have had a reasonable supply of those to deal with the Ebola crisis, not knowing that we would need them again for this current event. The PAPRs do come with these disposable options that we've been using in a fair amount for airway emergencies and in our critical care population. So we're really working with several engineers to develop in-house disposables to these PAPRs in case we actually run out of those, so that we have options if there are no other alternatives available. We're still bound by certain OSHA regulations to be able to, if we have them available, to supply those to healthcare workers. So we're using that as an option of last resort. And so those prototypes are still being looked at and tested. And as soon as we have something developed that's usable, that seems reasonable, we can roll those out when the circumstances warrant.
Thank you. Here's a question that perhaps could go to our infectious disease specialist. Is anything known about the durability of immunity to COVID-19? Sorry, the question just jumped away. I think maybe you answered it. Did someone answer it?
Just provided a website with some of the information. I think there's some information regarding immunity for other SARS coronaviruses. the durability of immunity for SARS-CoV-2 is still not well understood. We're still assessing and gathering more data about this. And as Dr. Hoffman mentioned, we are conducting clinical trials on the use of convalescent sera. But I think most people are thinking that hopefully it will provide lasting immunity. And I'm sure, Risa, you may have something else to add too.
No, I think we don't know yet, and it's a very important question that I think is going to receive a lot of attention.
Dr. Martin, there are two kind of related questions, and they do relate to comments that you made at the outset about the extreme financial hardship that the health system and school are feeling as a result of this crisis. And I think we all of us in the panel know how dynamic a process this is. We have 2 briefings a day because things invariably change between morning and afternoon. So I don't think we're going to put anything in writing about money at this point, but I do think we need to, we
Address it.
people who have asked us have deserved to have answered. So the 2 questions are, how is the DGSOM planning to survive the predicted financial deficit? Will discretionary funds be taken back? And also, will there be pay cuts to staff and faculty?
Yeah, well, thank you, Dr. Hyde, and thank you for those questions. I guess my first answer is we are planning to survive it. So in the how are we are planning to survive it. But this is, as must be aware to everybody, in addition to the toll that COVID-19 is taking on the health of our globe, it's also taking a very strong financial toll on our school, on the campus, on the health system. We've been very fortunate to have outstanding financial teams who have been modeling the impact that this is having. As I mentioned in my preliminary comments, the model indicates that because of the loss of professional fees to our clinical faculty, it will cost the school between $80 and $100 million over the last month. So what we're doing, I can tell you this is at top priority for us as we're going forward. We're preparing for the worst and we're hoping for the best. We're working with the campus, with UCOP, and looking at all possible solutions, some of which indeed, just as in the 2008 and 2009 financial downturn, do include cuts, not just to staff and faculty, but to senior administration. So I think we have to be prepared for a variety of solutions. And when I say prepare for the worst, but hope for the best, that's part of what I'm referring to. I believe deeply in the importance of our mission. I believe deeply in the importance of continuing to invest in every area of our mission, our 4 missions. The question about discretionary funds, what I can tell you is that we, just to be perfectly transparent, over my 4 years as dean, we've built up reserves so that we can really invest in programs. And in the last month, 80% of that has been basically, I don't want to call it lost, but taken up by the COVID-19 pandemic. So it is going to be a period in which we really are going to have a mind frame that is a team-based, mission-driven mindset going forward, where we're going to have to look at our resources and determine how we're able to best accomplish our missions with the impact that this is creating for us. And again, it is something that is involving our colleagues across the campus, UCOP, across the school and the health system, to try to model how we're going to be able to come up with solutions that are going to be realistic, but at the same time allow us to be impactful going forward. I also have Chuck Haychuk on from our finance team. I don't know if he wanted to add anything. As Dr. Hyatt said, this is such a dynamic situation. We just don't know how long this is going to last. And so we need to have incredibly careful dynamic modeling of the finances.
Thank you, Dr. Martin. Dr. Cherry, there's a question: how many healthcare workers have tested positive thus far, and can this information be added to the daily email?
Yeah, and I do appreciate the fact that people are looking at the daily email. I was wondering about the impact of that, and we've had so far 7,800 people sign up for the Qualtrics symptom tracker, so people are definitely paying attention. Of course, because we're taking care of individuals inside of our facility that are COVID positive, it does put our healthcare workers at some risk. And so the reason why we have that Qualtrics symptom trackers to be able to proactively be able to identify individuals that may have symptoms of COVID-19 and refer them appropriately into occupational health. I think I do want to state that we're obligated to report any exposures to the LA County Department of Health, and that information does get rolled up at a state level. Because of privacy issues and HIPAA and all of that, we don't comment on any numbers at this point in time.
No, I'm kind of beating up on you here because I know that you're getting ready to make
Sure, no problem.
a well-deserved retreat. But another question I think you've had some experience in is, what is the level of collaboration on COVID-19 with other healthcare organizations in Southern California, such as Kaiser Permanente, USC, and UC Irvine?
Yeah, so our main point of contact in terms of coordination around any kind of surge planning is really through the LA County Department of Public Health. As a matter of fact, just 2 days ago, we had a leadership call with them just to touch base, keep the lines of communication open, understand how their surge planning is going, and to offer any assistance and that we may be able to augment with regards to their planning as well. The county, has been thinking through this, quite considerably in terms of being a central resource for triage of patients should they be necessary to the naval ship, to St. Vincent's Hospital, a field hospital that they could set up, as well as being able to reallocate patients appropriately and send them to appropriate institutions that have capacity. So they already do have those plans, but they will be the central coordinating body for redirecting traffic as appropriate to those hospitals that have the capacity to do it. I think we're quite fortunate in that Ronald Reagan Medical Center in particular has the ability to convert all of our beds into ICU beds, and because of the gas lines that were laid out 10 plus years ago for the institution, and in our surge plans, we have the ability to actually be able to double our capacity and take care of up to 1,100 patients if we needed to, before using pop-off valves that exist through the county.
There's a couple of kind of department-specific questions that I think we will definitely refer to the specific departments. One about preoperative pediatric patients, and another that I received online that referred to a specific department. But Dr. Cherry, again, I think you've touched on this to some extent, but given the new LA law regarding covering noses, mouths when going to public areas, including supermarkets, are we requiring patients who come to UCLA Medical Center to cover their noses and mouths?
Yeah, and that's a good question. So the reason for wearing these masks in public, and I'll take that item first, is because we want to avoid transmission of the disease. This is generally passed on in the public setting through droplets. And so simple face coverings in the way that the mayor has suggested out in public can reduce person-to-person transmission. In the hospital setting, we also have the same concerns as well. And so if there are patients that have a high index of suspicion, or patients that are undergoing testing, what we do is we actually do put a mask on those patients. They tend to be a hospital grade surgical mask, so that if they cough or sneeze, it prevents the droplets from being transmitted to another healthcare worker. So we do that for patients, and we're going to see more patients if they're able to tolerate wear more and more masks during the testing phase. Fortunately, we're able to get back those test results in a matter of hours. So if they're low suspicion, those masks that we put on initially during admission can be taken off as soon as we get the test results.
Rob, also, has it been necessary to send any non-COVID-19 patients from UCLA to the hospital ship in LA Harbor?
No, that would be a facility that we would not generally use. And then the reason why is because our patients have just such high acuity that we would need to hold on to the overall majority of those patients. That ship would be mostly utilized for those patients that have discharge planning issues or concerns that prevent direct transfer to home. So there may be social issues, or there may be someone who's immunocompromised already in the home, like a transplant patient, and those individuals are more appropriate for the naval ship. We've actually had those conversations with LA County.
Here's a question that maybe Steve Smale or somebody else could take. Steve, the question is, will health systems or medical researchers / experts be involved in the development of Apple and Google's COVID-19 contract tracing initiative announced this morning?
I haven't seen that.
We heard anything about that?
Yeah, no, I don't think I can answer that until I learn more about the.
Okay, we'll have to look that one up and get back on it. All right. Well, Dr. Martin, another question regarding finances and resources, saying, I understand the hospital has just gotten large payments from Medicare today and will get more in the near future to support physician salaries. Will this be taken into account regarding perhaps not reducing physician salaries?
Yeah, thank you. I mean, what I can say about that is I would consider that one of the many solutions that's being looked at. And I do want to point out that, when I said that we need to partner, I think it's really important. It's not that the central dean's office is going to make all the decisions about this. We're partnering very closely with the department chairs and the CAOs to really identify programmatic priorities in the departments as well, so that as we go forward, we're able to determine collectively how we're going to manage the financial situation. So the Medicare, not that the payment, not that I'm trying to not answer it, but it is just one of the many solutions. There are other sorts of possibilities about federal bailouts, looking at many other solutions to manage, to determining how we can really minimize the impact on our operations. Thank you.
Gee, there was a really good one, but it went away. I wonder if somebody answered it. Well, Dr. Martin, I mean, here's for you and Dr. Smale, and it says this question is clearly premature, but what signs is the DGSOM looking for to begin to restart the research effort? Any thoughts about a possible timeline?
And Dr. Hyde, as you know, I'm going to have to leave.
Yes, and Dr. Cherry, thank you very much for your participation and all of your hard work.
Thank you, Dr. Cherry.
Okay.
Thank you.
Thank you again for being here.
Bye-bye.
Steve, you want to take that one?
You want me to read it again?
Yes,
What was the question again? I was.
Yeah.
Here we go. So it says the question is clearly premature, but what signs is the DGSOM looking for to begin to restart the research effort? Any thoughts about a possible timeline?
Yeah, so that's a tough one. We have not been deeply involved in the campus discussions, and it will really be their decision. And I have a call later today where I may learn more about what they're thinking, if anything. I have a feeling that the depth of thoughts will increase as the curve starts turning downward. And hopefully that will happen very soon.
I'm going to just add to that again, I think it's an evolving situation. I think we have to pay attention to our public health colleagues, our infectious disease colleagues, to their advice. This is a place also where research and universal testing and new types of tests that are serologic tests are going to have a really big impact on when business, not just the research labs, but when business reopens.
And if I might add, Dr. Hyde, just in terms of that answer in the education realms, it's the same sort of thing, all the same considerations. When, as I said earlier, when the students were, 30-year students were pulled, it was largely because of desire to kind of contribute to social distancing, but also other considerations such as the availability of PPE. So from an educational standpoint and preparing a future workforce, and our students and our house staff are going to be dealing with this pandemic for some time, even as it wanes, and need to be prepared to deal with these kind of situations over the course of career. So ideally, we want them to have that experience, but we want them to do it in a way that we can balance these considerations. So as availability of PPE becomes less of a pressure, that'll be part of the many considerations about when we return to more educational continuity. I also wanted to add something to Dr. Cherry's comments about partnerships, and just for folks to know that we're in regular conversation with our colleagues at all of our partner affiliates hospitals, both county hospitals, VA, Cedars, et cetera, around aligning practices, because of course we have faculty and particularly residents and fellows who move back and forth, and we're connected in so many ways, really tight connections around all parts of our academic mission and theirs. So as an example, as I mentioned, Dr. Perkins has a daily phone call with partners from the county system, and that's been extraordinarily helpful in making sure we're in constant communication about the nature of our current situation at each place and how it impacts our faculty and our trainees.
Can add that for laboratory research, I think I'd love to see a limited ramp up of research activities, at some point in the not too distant future, given that, many laboratories, it's very easy to maintain social distancing and very low lab densities, but still, make a lot of progress. It's not our decision, it's a campus decision, but that's something that I think we would like to see. There needs to be consideration, of course, not only for the research staff, where they can maintain low lab densities, but we also have to think about custodial services, DLAM, and making sure that that it's practical for them, and as well.
I just want to say Desert Horse Grant, who serves as Senior Director of UCLA Health Research and Innovation and Co-Executive Director of UCLA Biodesign, is nice enough to write in and say that we are getting 100,000 of the face shields from Apple. They are basic and won't be used for frontline care providers, but good for other types of employees. Desert, thank you for sending that along. There's a question here that I don't know that we're going to be able to answer, but it certainly has been discussed in the various briefings. It's, do we have any statistics on telemedicine usage among the clinical service lines and how this is impacting finances for the health system? I think we know, and please jump in, anyone, on this. I think we know that the telemedicine usage is increasing dramatically, being used to the extent that it can. And I think it's correct to say that there were certain bumps in the road in terms of getting it implemented, but those are largely have been resolved. In terms of the finances, I don't think anything that's going on now is helping. But I guess to the extent that these allow for visits that otherwise wouldn't happen, it does have a beneficial effect. And to allow patients to be seen in some instances who just otherwise would not be coming in at all. Anyone else have any comments on that? Clarence?
Well, I would just add that the payment structure for physician services is not different in telemedicine than it is in in-person visits, although obviously you can't do procedures.
Right. Dr. Braddock, you wanted to add something about partnerships with other hospitals?
I just was the comment I made a few minutes ago about just wanting to emphasize the partnership with the county VA.
With the county, right? Of course, yes. Okay, sorry.
Sorry.
Let's see. There's a question, is there a basic, and maybe Dr. Smale could take this, is there a basic science research committee developing the limited phase and plan to get labs up and running in a timely manner? It seems that we should have a plan to present to the campus as a whole, and why we would be able to implement it safely.
Yeah, I think Kelsey and I will both be, I have a call later today, Kelsey's in regular communication. I think we certainly, have our ideas of what may work, and we'll, advocate for those in those discussions. Kelsey, do you want to add more? I don't know.
I would add that, this is also, we'd love to hear from you, from your ideas. And we have heard from some people. And if it gets to a point, we could put together a group to start to think about ramp up mechanisms in the basic science labs.
a question that I've actually heard before in a different forum, and it's what about hazard pay for those on the front lines along the line, as would be done, I believe, as would be done in the military. I guess I can only say that the risk, the sacrifice, the service that our frontline providers are providing is not lost on any of us. While I haven't heard a discussion about hazard pay, the lack of that discussion should not in any way minimize our recognition of the tremendous service that is being given, and if the anticipated surge occurs, will continue to be given and will grow. I don't know if anyone else has a comment on that.
Yeah, I think that's well said, Dr. Haidt. I would just add that, in the many ways that our faculty, our house staff, our nurses, respiratory therapists, others who are, on the front lines, there are many other ways in which they're being impacted, things ranging from if individuals are caring for a COVID positive patient and are going to return home at the end of a hard day, how can they be, feel safe with their families, to, schools are closed and childcare has become an enormous issue. And obviously I know Dr. Cherry had to step off. There's a lot of effort, both health system leadership, us in the school, the campus, to address many of these things, ranging from healthcare workers who are caring for COVID positive patients and have concerns about returning home. There's lodging available for them. So all these things are ways in which we're kind of indirectly addressing what's behind that question. I would hasten to add that on the childcare front, there's a lot of great developments, but one of the things that's really been a wonderful volunteer effort of our students, I don't mean just medical students, but students from health sciences, graduate students have volunteered in hundreds for a variety of activities, ranging from, as was mentioned earlier by Dr. Cherry, they've been assembling face shields in a work that's been going on for a couple of weeks, and literally have produced almost 7,000 face shields that are actually in use. They've also created, and people should know about this, a very interesting volunteer organization, lacovidvolunteers.org. I'll put it in the on the Q&A just as if I can, or maybe I could send it around the chat. But basically, this is a group of volunteers who are available for faculty, for our house staff who are looking for help with, again, some of it's childcare, errands. They're just basically the spirit of volunteerism has just been wonderful. So that's another way in which I think we're really trying to support all of our community.
Actually, if Dr. Levine is still with us, Mike, there's a question. Is there any update as to how this will affect the academic clock for the researcher tracks? The clock is relevant for the professional researcher series. I think it would be the same answer for all academic personnel that you gave at the outset. Is that fair to say?
Yeah, that's fair to say. We're going to be very generous about time off the clock for individuals who request it. Typically, most of the requests for time off the clock have to do with childbirth and child care, or sometimes taking care of individuals who are ill. But we're going to include this year, well, we've always included, but we're going to be more cognizant of those who wish to have time off the clock related to COVID-19. And it goes across all the series where time off the clock is relevant.
Here's one perhaps for Dr. Hoffman or Dr. De St. Maurice. Are there research studies currently enrolling for serologic testing? If yes, could information be provided about enrollment?
There is going to be a healthcare worker study, and it's, I think, slated to open next week. I'm not sure the mid-nasal swabs for PCR testing will be reported to the participants every 2 weeks when they're collected. I'm not sure that the serologies that are collected monthly are going to be reported in real time, but I think it's a great study and will help us understand, answer a lot of questions about COVID in our healthcare workforce. So once we have recruitment materials and a clear start date, we'll definitely be disseminating that to all faculty and staff.
Here's one I'll send to the two of you also, and this is one where we're all going to be a little bit smarter when we leave. If someone is, or at least I will, which is not saying much, but if someone is exposed, infected with COVID, how soon after exposure or symptom onset would serology be expected to become positive, either IgG or IgM?
I mean, Annabelle, I'm not sure if you have more specific information, but from what my reading, it's actually a relatively short timeline between development of antibody, especially IgM. So I think that the bigger use for the serology is probably going to be, though, in looking at if whether people have had past infection. But I think there's a lot more to consider there. Annabelle, I'm not sure if you have other info.
No, I agree. I mean, I think it's up to several days for development of IgM, but I think, as you mentioned, the more useful of these is PCR for acute infection, just given that IgM may take some time to develop. But the IgG is really helpful because it does tell us about past exposure for healthcare workers or other situations. So I think that might be helpful, but we still don't know the duration of immunity. So there are still a lot of unanswered questions about serologic testing.
And this is, I can add, this is Steve, I can add just that this is a really fast moving field just over the last 1 or 2 weeks that, there's dozens of tests that are becoming available, but still not entirely clear which ones are, high quality tests, which ones are showing the appropriate specificity, which ones will actually be useful in a clinical setting versus a research setting. It's unbelievably fast moving with a lot of uncertainty, but it'll get there as we work through all of that.
There's a question, if we do need to make faculty or staff pay cuts, will the university take into account those who were frontline workers in the crisis? I think, I guess I'll just start by saying that, first of all, the university, the school, the campus, and the office of the president have really been working overtime to try to respond, from my perspective, in a way that is the least injurious possible to all of our employees. I don't know that we can answer this question now, but I think everything is being done to recognize the enormous sacrifices that are being made by everybody as a consequence of this crisis. I don't know if Dr. Martin.
Yeah, I mean, I think it's a really important question and comment, and I would echo your statement, and that we are all so incredibly grateful and appreciative of frontline workers that there's a deep commitment to ensuring that those individuals are recognized. And I think that I have to leave that we have to take that into consideration whenever we're approaching any approaches to mitigating the financial impact.
Here's a question for our ID specialist, or maybe I think you answered it. It went away, so it must have been. It was a good question, though. It was the temperature degrades the virus. I'd really love to know that. Can you answer? Can you say how you answered it?
I shared a paper from the Lancet regarding the stability of SARS-CoV-2 in different environments, and it talks about stability at 4 degrees sensitive, but states that it is sensitive to heat. So I think that is good news, and that if it was incubated at 70 degrees Celsius, which is obviously very hot, that the inactivation of the virus was reduced to 5 minutes.
And another question, how soon will the rapid bedside molecular test for virus using reverse transcriptase and PCR become available?
So I think that's a great question. We've been in constant discussion with our laboratory about the utility of this test. I think there are some challenges with it, including some of the tests do require still a lab certified personnel to perform the rapid test. So it's not really rapid, but it is much faster than the 4 to 6 hour time. So it's not technically a bedside test. And we're still continuing to look at that as an option. But Cepheid, which is one of the manufacturers of the rapid bedside test, has not had enough of the machines that run the test available. So our lab's been inquiring about it, putting a lot of pressure on the manufacturer to see if we can get it. But we're still kind of in the process of looking at that. So hopefully more to come soon.
I think we've made our way through most of the questions, and it looks like the audience is beginning to tail off somewhat as everybody goes back to work. So I want to begin by thanking the panel for participating today and thanking all of the faculty members who joined the webinar. And I'm going to take the privilege of the floor once again to make one final pitch. You've heard from a number of us about the Cultural North Star, one of the signal accomplishments of Dr. Martin's deanship, and appropriately the background she's used on screen for this meeting. Dr. Gordon spoke about the Cultural North Star, as well as a set of principles that guide us to do what's right, make things better, and be kind. We use these principles day by day, but I wanted to single out the last one because it is so important. Be kind. If each of us were just simply kind to one another, about half of what I do in my vice dean role would simply go away. I would have to find other work, but it would make me very happy to have to do so. Please be kind, not only when times are hard, as they most certainly are now, but because times are hard. Be kind. As we conclude today, for those celebrating holidays in this season, I wish the happiest and healthiest holidays possible given the circumstances. And once again, I thank all members of the faculty for your extraordinary hard work now and into the future. Thank you.
Thank you.